So hereby I open this academic ceremony in which Martinek will defend the academic thesis, Contemporary Atrial Fibrillation Management, Healthcare Expenditures, Treatment Methods and Outcomes. And may I invite you to present a summary of your study and the conclusions of your thesis.
Highly esteemed Prorector, members, this is my dissertation at the University of Maastricht, and you already heard the title, and it's all around atrial fibrillation. And atrial fibrillation is the most prevalent arrhythmia that we face in cardiology today, and it was in 1989 when Michel Hesseguer described these extra beats from the pulmonary vein as the source or the triggers for this arrhythmia. And that's where the idea came from, that we could do an isolation of the pulmonary veins, and so to isolate the triggers from the rest of the left atrium to get rid of atrial fibrillation. And the first method was radiofrequency ablation, as you see here, a point-by-point ablation through the antrum of the veins. And the second was the cryoballoon, which was also established quite early. And nowadays we also have a third thing, which is PFA, pulse field ablation, but that was not in my papers because it's just on the market for 2 years now. And all the papers you see in my defense are circling around pulmonary vein isolation. I will first go for the topic of first line PVI, then better technologies for treating patients, better treatment targets, especially in persistent forms of atrial fibrillation, and then money allocation, because that was the main paper we published with the Maastricht group, and all for improved patient outcomes. That's the goal, of course. Let me go to the first topic, which is first-line pulmonary vein isolation. That's the paper published in Europace in 2021. A former fellow of mine did a pooled analysis of randomized data, and the randomized data were these 5 randomized studies comparing catheter ablation versus antiarrhythmic medication as a first-line treatment. And these were quite recent studies with cryoablation, stop AF and early AF, and the others were radiofrequency ablation studies. And you see, all favors the ablation against antiarrhythmic drug therapies. And of course, we have also to ask then, is it safe? And yes, it is. Catheter ablation and antiarrhythmic drug therapy is quite the same if you look at serious adverse events. And that's also why in the latest consensus statement, which was just published this year, for paroxysmal atrial fibrillation, when patients are symptomatic, first-line treatment with catheter ablation is deemed beneficial. Oh, sorry, it doesn't move on anymore. Yeah. Second topic is technologies for ablation. We always struggled that the lesion set is recovering and that the isolation is not durable. So better tools are needed to do it. And that was one of the tools. It was the Q.FAST trial where we evaluated for an FDA study this new catheter technique. And you see here there are 6 thermocouples in the radiofrequency head of this radiofrequency ablation catheter, and that gives back temperature feedback. So we can deliver much more power, up to 90 watts now, with a very short lesion, only 4 seconds needed. And that's very much different from the old forms of radiofrequency ablation, where you need to deliver 20 to 30 seconds for each point with 40 to 50 watts. And that, of course, spares a lot of time. Procedure time is around 105 minutes. And that's the all the studies with radiofrequency catheters, and you see that's around double of it. Ablation time also goes down from around 110 minutes to 46 minutes, and the RF application time, the actual time you deliver energy, is only 8 minutes now instead of 50 to 60 minutes. And also the fluid delivery is much less because the time needed for ablation is much less, 1.8, 1.6 liters with the old technologies, and now it's only 380 milliliters, which is very good for patients that are also having heart failure. Is it safe? Yes, there was only one thromboembolism, which always can happen if you are in the left atrium in the whole study. And we also tried to evaluate this technique in a short pivotal trial with around 50 patients in our center. So this is the next paper here, a very high power, short duration ablation against a normal ablation setting with 50 watts. And you see as well that you spare around 15 minutes per patient because you have a lower atrial dwell time and a lower ablation time. And still you get the same results. We did Holter patches after 12 to 18 months to evaluate that, and also FAQ questionnaires for quality of life of the patients. And you see it's quite the same with around an 80% clinical success after around 1.5 years. Treatment targets. We always struggled with persistent forms of atrial fibrillation. Because there it's much more difficult to get the problem done. And so people were thinking what to do after pulmonary vein isolation. And this is one of the studies we published with 5 centers in Germany and 1 in Czech Republic and 2 in Austria, the low voltage myocardium guided ablation trial. And we randomized people to PVI alone, as you see here in the B plane, versus taking out low voltage areas, diseased areas with low amplitude signals. And if they were on the posterior wall, like you see here, we just took out the posterior wall with a box lesion. 320 patients were randomized. Around 34 to 39% of them had low voltage areas found. And that's just examples. If the low voltage area was here at around the left atrium appendage, we took out this small area, or if it was at the posterior wall, we took out that, or septal ablations like you see here. It's not moving. It's thinking. Sorry. The system is just thinking about it, and now it's going on. Okay, and with this approach, so the pulmonary vein isolation plus the substrate modification of these low voltage areas, we got a big difference in the 1-year follow-up. So 15% absolute risk reduction for atrial tachycardia or atrial fibrillation. So this is a huge difference. And in the secondary analysis were only people with loop recorders, so 100% follow-up. And also here we find this 15% difference. Antiarrhythmic drugs were not different, and less reablation procedures, of course, in the PVI plus group. That was also taken in the recent meta-analysis now from Harvard group. And you see ARRAISE was the biggest of these studies, and all of these studies doing more than PVI with low voltage areas were positive for efficacy. The last point is money allocation. We did a first study in Linz with Professor Bruckner for the impact of catheter ablation on our healthcare expenditures in a cohort of 1,100 patients undergoing PVI with 268 with multiple procedures. We analyzed the true healthcare expenditures and the outcomes. And we saw that days of hospitalizations and days of sick leave started to rise in the year before pulmonary vein isolation because people had their first episodes of AF. And the ablation was able to lower both parameters to the level 1 year before ablation in these patients. And comparing 1 year before and 1 year after single index ablation, a significant reduction in overall healthcare expenditures could be documented. That's the hospitalization days, so they go down again to the level before, and also the sick leave days, as you see here. And this is the cost data, the total expenditures, and we analyzed up to 4 years after the PVI, and still the effect was given, and the expenditures were lower than before. The last paper, which was published with the Maastricht group here, were now patients treated with drug therapy versus patients treated with PVI. In a cohort of around 22,000 people first hospitalized in Upper Austria for atrial fibrillation, we took out with propensity scoring a cohort of around 1,000 patients that were underwent PVI and 1,000 that were non-PVI patients. Over a 10-year period, we could see that the PVI treatment strategy reveals significantly higher inpatient and outpatient expenditures, around 2,200 euros per year per patient. But we get a higher employment rate, around 5 percentage points, so absolute differences, and around 7.6 percentage points fewer retirements. So this is, of course, very important for socioeconomics, because these people pay into the system. And of course, for the patients, this is the most crucial thing. We also saw a 5.8 percentage points, so absolute reduction in all-cause mortality over 10 years. And this is the graphs. This is the DRG, so this is the costs. And you see the PVI group still remains a bit higher than the other group, but mortality really divides already after the first year after pulmonary vein isolation. And we thought this is not only PVI itself, so it's not causal, but I think it's early rhythm management, it's strict risk factor assessment and treatment, it's a more rigorous medical workup and a tighter medical care. So it's not only the procedure itself, but also medical care. So to conclude, the first-line PVI clearly provides benefits over antiarrhythmic drugs and therefore should be offered to our patients. New methods are needed to enhance effectiveness and efficacy. New treatment targets like low-voltage guided ablation could improve outcomes. Healthcare expenditures for PVI are a reasonable investment in our patients, and PVI impacts socioeconomic factors and might even improve mortality. And what's the impact of my papers? 2 of these papers have been cited in the 2024 consensus of atrial fibrillation ablation, and 8 of our papers from my hospital were cited there. First-line PVI is already recommended, as you saw, for symptomatic paroxysmal AF. New technologies are widely used in radiofrequency ablation. New treatment targets have been discussed in the consensus. It's a you can do, but it's not a you should do. We will see. The evidence is growing. And various health technology assessments for PVI, also in Austria, have been positive, and more money is now allocated to electrophysiology. And I thank you very much, and I hand over the microphone to the pro-rector. Thank you.
Thank you for your interesting and informative presentation. So both of your paronyms may take their seats to avoid collapse or anything else. So the opposition will be opened by Professor Vernooy. He's a chair in electrical management of heart failure, and Professor Vernooy is the chair of the assessment of your assessment committee.
Thank you, Mr. Pro-Rector. Dear candidates, first of all, my sincere congratulations with this achievement. Very well done that you took the effort to really finish this PhD thesis. I know it's quite a lot of work at the end, and when you're busy in the clinics, even heading the Department of Cardiology right now in Linz, it's quite an effort to achieve this. But I'm really happy that you did, especially seated mostly in countries who are German speaking, of course, that is somehow different across Europe, and it's really well done that you achieved it. Nice to see that after DASCOM that you managed to do this all after the second DASCOM group, I believe. So with that, and of course, I also like to congratulate, of course, the promotion team who I think played an important role in this. But I would like to start with some questions because that's why we're here, of course. And I would like to start careful because the pro-rector really told me to be sweet to you as a first. So we'll go gently and maybe as cardiologists amongst each other on EP. I was thinking about actually your second scientific paper in your book on page 37. You also showed this picture in your presentation. I would like to go through these graphics and see, is this typically for a general AF population? Is this Austria? Mm-hmm. What would happen if I would do the same in Maastricht? So, for example, if you look at figure 2 at page 37, you see that figure 2C, that there is actually a gradual increase in the days of hospitalization per person and quarter preceding the procedure. Mm-hmm. And actually the quarter of the procedure itself is very high, with 10. Can you maybe explain why this is so high and why this is gradually increasing before the procedure? And then also answer the question whether this is typical for Austria or would it be the same across Europe?
Mm. So highly esteemed opponent, thank you very much. Of course, we have to keep in mind that these are data from 2005 to 2018. In the early days, I think people in Austria for a pulmonary vein isolation were in hospital around 5 days. Now it's 1 or 2, so it's of course decreasing. And then you have also people coming back for cardioversion. And the quarter of PVI, so it's 3 months, maybe they have been in hospital to check them for coronaries, to do a first cardioversion and so on. So I think today it would be at around half of it. But of course, this is an old population starting in 2005. And I think today it would be at around 5 days.
Okay. And so you already give a little bit of the answer is that it's older data. With that time difference that we have, we also had new techniques, amongst others you showed one. Would you guess that this can be even more influenced by the technology we use nowadays?
Maybe yes, but we did half our cohort in an older cohort, 2005 to 2012, and then a newer one, so 500 patients each. And for the outcomes, for the raw outcomes we report here, there was no real big difference. So I think the faster technologies came into the market in the last 5 years maybe. Mm-hmm. So that is not in the scope of the paper. And now, of course, we are speeding up with pulsed field ablation, and people are maybe go home the same day. So I think we have to do that because we have to be more efficient and we have to treat more patients. But that was not the case in these days.
Okay. Then if we look at 2A, that was really intriguing actually, that the amount
Dr. Van Nooy, could you please, for the online audience, use...
Yeah, so if we look at 2A, if you look at the picture, that is really intriguing that the amount of euros spent on medication expenditures actually increased after the ablation procedure.
Yes. There has been, in the supplements, it's also described, or it's written in there, we have more patients on lipid medication. We have more patients on antihypertensive medication, more patients on antidiabetics. So I think the treatment of these patients going into PVI is much more strict than on non-PVI patients, maybe just on rhythm control. And I think that also makes the difference. So we have a better spotlight on these patients that we treat with an aggressive approach like PVI.
Okay, but then if I may interfere, that's strange because these are all PVI group patients. So even before the procedure, they will become PVI group patients. So actually they receive a better treatment thanks to the PVI.
I think that the PVI is just the landmark where we set our zero in the study. But I think the PVI is also where we think about other problems of the patients, which we did not see 2 years ago. But then they come into hospital for a first hospitalization for atrial fibrillation. So this is the point zero, let's say it like that. And then we think about hypertension, lipids, and so on, and we better treat them.
So we think of a PVI before we think of the hypertension?
Yes, I think so.
Okay.
Yeah.
So shouldn't we more focus on that then during our...
Absolutely. I fully agree that prevention would be much better than doing something against the disease already. But in our systems, we are not there yet.
And we are APs. We like to put catheters in, but shouldn't we send the patient back to refer before we start performing the PVI and get them back when they're well treated before we actually do the ablation, because that might be eliminate maybe half of the patients after all?
To be honest, in some patient sets, we are already doing that, especially in very obese patients, because we know that obesity is also a trigger for outcome and for redo procedures. And we try to really get these people on a weight loss therapy. Also nowadays with GLP-1 medications or whatever. And we try not to treat them if they have a BMI of more than 35.
Okay. Interesting that you mentioned redo PVIs. Last question, Mr. Prorector, is that most of the significant differences are actually gone as soon as it concerns redo PVIs. And we know much more that we are changing from paroxysmal, we're doing quite well, to persistent AFib, where very often we're not done with one procedure. And it seems that most of the advantages is lost. Should we then really put all this effort in these patients, or we should maybe be a little bit reluctant?
I think reluctancy is okay because our space is limited. So of course, it would be better to treat the better patients because they have the better outcomes. These are the younger patients without many risk factors. But on the other side, and I discussed that a lot with Professor Bruckner, we can also put money in patients, even if it costs money, if the outcomes after a while are better. And outcomes might be socioeconomic ones, people can work again, they don't retire, but also, of course, then mortality is the ultimate outcome. So we do other things that cost money, but we always have to think how much per patient is okay for our systems. And as you have heard in my presentation, I think 2,000 euros per year is not too much. If you think about dialysis, this is 50,000 per year. So I think we can put some money into a patient even if we have to do a redo procedure.
Thank you very much. I'm very happy with the answers, and I would like to give the word back to the prorector.
The opposition will be continued by the second member of your assessment committee, Professor Brunner La Rocca, and his expertise is cardiology with a focus on clinical heart failure, and he is based at our Maastricht University hospital.
Yeah, thank you very much. Dear candidate, first of all, also my congratulations for your effort and your thesis, and I also would like to include the promotion team with that. Before I actually come to my question, I actually would like to continue on what you just said, because I think that's interesting. How do you think we could actually identify patients where particularly the more difficult procedures actually should be given, whereas, where we actually should say this is not really worthwhile doing it? I'm just curious to hear your thoughts on that.
Highly esteemed opponent. Very, very nice question. I think, of course, the easy patients are the ones which we call low atrial fibrillation. So no risk factors, maybe a bit of hypertension. And I think these people are very well treated also today, also with our new technologies and faster technologies. The real hard nuts to get, I would say, are the persistent ones, or the long-lasting persistent patients. And I think we have to be faster to include these patients in an aggressive strategy to get back sinus rhythm. So not wait for 3, 4, 5 years, because then I think you have to go to Maastricht for a hybrid approach, which is a very good one for long-lasting persistent patients. But, you know, it's also very expensive.
Yeah, sorry to interrupt you, because you just said we should wait for more or longer and should treat risk factors, but now you're saying we should treat them earlier. I'm a little bit confused.
If atrial fibrillation comes up the first time, then we should treat them early. And not to get atrial fibrillation, we should treat our risk factors. Not only for atrial fibrillation, also for coronary disease, also for heart failure, of course. I think that's all in line. It's hypertension, it's diabetes, it's lipids, it's smoking. So it's all in line here, where we really can save our patients from getting into the problem. But if we see the problem of atrial fibrillation, we should treat it early.
Okay, so you want to see all my patients that I see that somewhere or somehow had atrial fibrillation. I think that will be quite a challenge also to the electrophysiologist at our department.
Absolutely, but I think heart failure patients, even if they are on a good heart failure therapy, you will see a regression of atrial fibrillation. And it's not only ablation therapy that can solve the problem. As we have seen in large population trials, it's also antiarrhythmic therapy you could do. It's even pacemaker therapy with a blade and pace therapy. So it's not only pulmonary vein isolation.
Okay. Now I want to come to the question actually I have prepared, and I also want to go to the second publication regarding just the implications on costs. You used a pre-post design for analyzing that. Can you maybe just elaborate a little bit about, just the advantages, but maybe also the limitations of using this design?
Well, in our database, so it's a huge database from in and outpatient data in Upper Austria, and we had to set a time point 0 for both of our studies. For the study you mentioned, this is the pulmonary vein isolation. This is set as the point 0 for the patient, and we had to look a reasonable.
Well, I know how the design actually is set up, but what is the advantage, but maybe also the limitations?
Well, you know, we had a data set from 2005 till 2015. So we tried to have patients in that we know from before, at least 2 years, to know what was the cost they used for everything in healthcare. Not only atrial fibrillation, but everything in healthcare, even if they broke their legs or whatever. And we thought that would be a reasonable amount of time until we get to the time point of PVI. Because PVI is not done immediately if you are first in hospital with atrial fibrillation. In Austria, you normally wait 3 to 6 to 9 months. So we thought it would be reasonable to have 2 years before and then at least 2 years after to have something to compare with and to see if with the PV isolation we could set this patient to the baseline level.
Well, can you really answer this question? Because you have not answered the potential limitation of this approach. Of course, you would like to have a randomized controlled trial, and then you can address it. So why is this the case, and why we're not just using pre-post analysis also for other, treatments or interventions?
Well, you know, that's the data that are in our database. It's not a randomized trial, it's just a cohort, of course, and that's what we choose to take out of these 10 years we had. So of course it's not a randomized comparison, it's a per person comparison.
I know, but you're not answering the question, what are the limitations of a pre-post design?
Well, the limitation is that we don't know what was in the time frame 2 years before, and also then after the time frame, you don't know anything about the patient anymore. Of course.
Well,
That's.
Just leave it. Maybe just a very short final one for me for understanding. In your calculations, you did not consider the cost of the intervention itself. Is that true?
Yes, that's right. In this second paper, we did not. In the paper with the Maastricht, yes, we did. Yeah.
Okay.
So the one was really a pre-post analysis, and the other one was total cost, also including the PVI and also redo procedures.
I think it should have been done also for the second paper, but anyway, I'm satisfied and giving back the word to the prorector.
Okay.
Thank you.
Thank you. The opposition will be continued from Hamilton, Ontario, Canada, early in the morning by Dr. Nieuwlaat. He's an associate professor, health research, methods, evidence and impact at Maastricht University. Dr. Nieuwlaat.
Thank you very much, Mr. Prorector. Just making sure, can you hear me well?
Yes.
Okay, thank you. Yes, so first of all, happy Canada Day. Here we have Canada Day, so that's something we celebrate instead of a King's Day in the Netherlands. And today I just want to ask some questions, also perhaps to see how this country can benefit from your findings as well as perhaps other countries. I'm a methodologist, so I will primarily focus on some of the research methods issues. So first I would like to, I'm sorry, before I continue, congratulations, of course, to you and your promotion team with a very nice thesis. It's a lot of work and you've used different types of research design, so very nicely done. My first question is about the study where on healthcare utilization and outcomes where you used propensity score matching. And I would like to know from you, you selected 1,013 matched pairs based on propensity score matching. And can you tell me what's the potential consequence of selecting these patients and these matched pairs instead of the full cohort of 21,791 patients? That also includes all the patients that underwent pulmonary vein isolation. So can you explain to me why you made this choice and what perhaps could be the benefits and as well as downsides of using this method?
Yes, of course. So esteemed opponent, we had these 21,000 patients that were first hospitalized for atrial fibrillation, and only 1,600 of them had a PV isolation. So we thought about how to match these populations. And as you maybe have seen in the supplements, if we would not have done matching, the PVI and the non-PVI cohorts would be very much different. Because the PVI cohort is much younger with less comorbidities. It's around 55 years of age, and the other non-PVI cohort is around 10 or 15 years even older. So we had to decide how to match it perfectly. And as you see here, we had the decision, and we did a lot of tries. We first started off with the CHADS-WASC score, because that is our score that we normally have in these patients, of course, to say if they have to be anticoagulated. And then we thought about, okay, if we want to look at mortality, renal failure will be one of the key factors. And in the cardiovascular world, also hyperlipidemia might be a key factor for mortality. And then we also wanted to put in a socioeconomic parameter, because we know that socioeconomic status, the color, blue or white color, is a key risk factor for the development of atrial fibrillation. And it might also trigger a PVI or non-PVI strategy, because maybe these patients don't go to the doctor that much, or can't afford go to the hospital or whatever. So I think with this propensity score matching we had all Jadrowski parameters plus socioeconomic parameters in. And of course we lost, and that's the limitation, around 600 people that were having a PVI, but with the perfect matching, and we did a 1-to-1 matching. And as you have seen in the supplements, it's really a perfect match. So it's nearly a 1-to-1 match with the propensity score we got. So I think we thought that would be the perfect matching parameters for the study.
Great, thank you very much for explaining that. And indeed, as you reported, they are very closely matched. I guess the alternative, you clearly explained the alternative of doing perhaps a multivariable analysis using the full cohort would be less ideal because the differences are so big. I think that's what you're saying. But you also report in terms of the patients that underwent PVI and that were not used for matching because you could not find a close match. I believe they were, let me look here again, they were older, more often female, and healthier. So can you perhaps, would it have been an option to include them, perhaps with less ideal matches, to still have a larger cohort that's matched, although not as closely as perhaps the ones you used?
Yes, we have tried that with other parameters or with taking out parameters. We first started off in the first analysis only with the Jadrowski score, because there is age and also sex inside. And then tried, but the fit in propensity score matching was much lower. But the results were quite the same. So we tried to have a perfect match instead of have all the patient in. But I fully agree that our cohort is a very young cohort because it's a working cohort. That's because we had the blue and white collar workers inside, and they had to be at least in white or blue collar in the last 8 years before the first atrial fibrillation hospitalization. So these were really working class people, let's say it like that, and that's why the population is so young. It's 55 years in average, which is not our normal population, but I think this is the population we try to treat early and strong.
Mm-hmm. Thank you. And if I have a bit more time, then I would like to, as a follow-up, ask in terms of knowing the characteristics of this population. And you indicate in your thesis you would like to see that your work is being taken up by guidelines or updated guidelines fairly soon, I believe. To what extent can you consider this analysis applicable, or what is the external validity to other, the broader population of atrial fibrillation, and as well as, for example, considering contextual factors to perhaps other areas in Austria or other European countries?
I already have stated that I think we should treat the patients as early as possible. But if you, of course, look at the age, and we also did an analysis in the second paper of the age groups, then the younger patients benefit most of a PV isolation. So, of course, we have different cohorts that will benefit most, but still I think PV isolation also now gets to the older patients we have to treat. And if we are able to treat them early with safe procedures that might also get cheaper because we are doing a lot, then I think we should also offer this to older patients up to, let's say, 80 years of age.
Okay, thank you. I think I will give it back to the pro-rector at this point.
Thank you, Dr. Nieuwlaat. We appreciate your presence in this degree committee from this distance. The additional opponent is Dr. Kimman. She will continue the opposition. She's a senior researcher with an expertise in health technology assessment and works at the ChemTA department of the Maastricht University Medical Center. Dr. Kimman.
Thank you. Dear candidate, it was a real pleasure to read your thesis, and I congratulate you and your team with this great achievement, and I think it has already maybe changed clinical practice or is likely to change clinical practice. As an HTA researcher, I was mostly interested in your health economic analysis that made use of real-world data to estimate the healthcare expenditures for PVI versus drug therapy. That is, from my point of view, a very relevant comparison. So you acquired a very impressive data set and showed that the patient group receiving PVI had greater healthcare expenses in the short and the long term, and which has been mentioned today before. This was attributed to the high cost of the intervention itself. It was around, I think, 10,000 euros.
Yes.
And repeat procedures, but also increased expenses for other healthcare use, such as pacemakers, cardioversion, various medications for other diseases. So while there's a slightly lower mortality rate in the PVI group, looking at these higher healthcare expenditures, I wonder whether it comes at a cost of quality of life. Due to these complications, side effects, and other unforeseen patient-relevant health outcomes that need to be treated with all these other healthcare expenses. So in your propositions and also in your summary of your thesis, you state that PVI is a reasonable investment. And as a health economist, I would then like to know a little bit more about whether the additional costs of PVI are acceptable when related to health benefits. So my question is if you could elaborate maybe a bit more on how or if and how patient-reported outcomes, such as quality of life, but also cost-effectiveness considerations have been incorporated into this evidence generation process to assess the value of PVI for AF patients.
So these two economic studies did really look at not quality of life, so no QALYs or ICEs. We really looked at the in and out patient costs on the one side and on hard endpoints like mortality or socioeconomic things like other people still in the working force. But on the other hand, with our other studies, we showed that quality of life, because that is in the one study with PVI isolation with the new catheter technology, that these people with the new technology seem to benefit better related to the AFAC questionnaire, which is a quality of life questionnaire. So it's not only a better outcome or a shorter treatment period that helps quality of to gain quality of life, but we did not include that into our socioeconomic papers. So it's not a quality analysis, it's just pure cost analysis there.
Yeah, I realize. And in your meta-analysis, I think that was also versus drug therapy, there was sort of equal quality
serious
of life,
adverse
right?
events, yeah. I think it was astonishing, and also in very big studies that we have seen in the last years, where we have treated patients with ablation therapy versus drug therapy. Drug therapy also does adverse events, because people have to stop these drugs, because even if you think at amiodarone, with a lot of problems with the thyroid, with sleeping disorders, with shaking and so on. So this is not a treatment that does no harm. So we have to balance that. Of course, the problems we get with ablation therapy are very acute normally, because it's bleeding, it's tamponade, it's stroke. But then if you go over this ablation treatment, the serious adverse events will go down, because you don't need so much antiarrhythmic drugs. You might even stop your anticoagulation, so no bleeding risk, and so on.
Although that's not really shown in your health utilization papers, right? Because the drug therapy was still very high in the PVI group.
Yeah, there is still at around, in all the papers it's a bit different, because it's different by cohort, of course. But if you take the persistent atrial fibrillation paper, it's around 11% still in the PVI group. And that's why we also stated in the health economic paper that this is not PVI, it's a PVI strategy. And sometimes you still need antiarrhythmic drugs to stabilize the patient also for a longer time. And of course, it's just depending on the Jadz-Vasc score, of course, if you stop anticoagulation, for example. So it's a strategy, it's not a therapy alone.
Okay. Thank you. And maybe as a follow-up question, we already discussed that personalizing this treatment may benefit cost effectiveness and patient outcomes, maybe better. So this can be done by research, more research to identify patients that benefit most, but maybe also by shared decision-making in the clinical encounter. Is that something, could you maybe explain to me how does this work in clinical practice? Do you discuss with the patients? Do they have a choice? And how do you engage them? And do they all opt for this treatment?
Yes, we do. We do discuss it with the patient. Even nowadays, we already discuss the ablation strategy with the patient, because now we have at least 3 methods, so radiofrequency, cryoablation, and pulsed field ablation. And pulsed field ablation seems to be very safe, but we don't know if it's effective enough like the others in the long term. So we really try to also give the pro and contras to our patients. Of course, antiarrhythmic drug therapy is also an option for them, because if we see the NOAA trial or other big population trials, then also antiarrhythmic therapy is an option to have a better outcome. So it's not only aggressive ablation therapy. And this is just a personal statement, of course. I try to do the low-risk patients as early as possible, because their chance for a long-term benefit is, of course, the best. And in other patients where we have to treat a lot of comorbidities, I think we should really keep an eye on them first, and then see how they manage or how they go on with the atrial fibrillation, because there we will have maybe one or more procedures.
Okay, thank you. I'll give the word. I was satisfied with your answers. Thank you very much.
Thank you very much. The opposition will be continued by Dr. Beukema. His expertise is cardiology and is working at Radboud University Nijmegen. Thank you for the
Thank you very much.
Great journey you have undertaken.
Thank you. First of all, I want to congratulate you with a wonderful product and your team of supervisors. My question is also about the first publication in your thesis, and it's a bit in line with the previous opponents, but also on the discussion of the last chapter. You demonstrate in a very large cohort in Austria that there's a lot to gain with PVI with these patients. You know, these people have longer years of employment. From other studies, we know that quality of life is better. Even mortality in this study is improved. And your conclusion, or you emphasize in the discussion on more faster, better efficiency, and actually improve and be able for a lot more patients for this treatment. To be a bit provocative, I would stand out for the conservative arm and the conservative treatment. You also demonstrate in your articles that that the treatment, particularly this treatment of usual care, is in fact undertreated, isn't it? They have less coagulation, anticoagulation, yes. Limited risk factor management as compared to the invasive group. And from the EAST-AFNet trial, we know that the monitoring ECGs, Holters is less as compared to the invasive treated group.
Yes.
So I would plead for identifying these patients. I mean, we know that in the long term, it's more than 20% who are not successful in obtaining sinus rhythm. So in fact, you may say the treatment, the invasive treatment, is rather poor. So shouldn't we really identify these patients and treat them conservatively, or either with rate control and then with proper rate control and risk factor management? This may reduce waiting lists. There's more capacity for patients who will benefit from the procedure. And also from a health economic point of view. So what's your opinion? And if you agree, how do you think we should investigate and how should we pick up that treatment for the conservative arm?
Mm-hmm. So esteemed opponent, I do not fully agree, let's say it like that, because I think with the East AF-NET trial, we have clearly seen in a first-comer population of atrial fibrillation patients that first come into our hospitals, that aggressive treatment of atrial fibrillation is beneficial. So I think if you count antiarrhythmic therapy as conservative therapy, I would agree. That's for me also a conservative arm, because we don't do an ablation, of course, in them. Mm-hmm. But I think our goal should be to bring the patient back to sinus rhythm, because I think that has been shown that this is beneficial. Of course, I agree that after years and years of atrial fibrillation, there will be patients where we don't have a chance for that. And that's where I agree with you. With these patients, I think we should go to other alternative therapies, because the invasive treatment strategy is then too late. And going back to the discussion before, I think we have to be more aggressive in prevention of all our cardiovascular diseases, and of course atrial fibrillation is one of the most prevalent ones, but I think that's where we have to put most of our efforts. And we as clinicians, we treat the patients, but we are always too late already. So I think the prevention would be the number one, but that's not our focus, I would say.
Thank you very much. I think as well, prevention, there's a lot to gain as well. But do you think the recurrences, and in the first article, so 26% of patients have a second or a third or even a fourth procedure. Do you think these patients, they come really as a surprise, or do we beforehand we can predict it's these patients who will recur? And you know, these patients, they have a very poor quality of life, in fact, isn't it? They are long on the waiting list for 3 procedures. They are for years on the waiting list. And we know already long-term outcome, we wouldn't reach a long-term outcome.
Yes.
Do you think we can predict it beforehand?
I think, of course, in patients that are younger and have lower comorbidities, I think the chances, of course, higher for a long-term benefit of a single procedure. Yes, I agree with that. And on the other hand, I think we also have to drive our ablation therapies to better isolation of the veins, because we still, after 20 years of doing that, are not perfect with that. And I think that's where we can still improve our outcomes. Still, for most of the patients, I think we have to try to get them into the sinus rhythm again, with all possibilities we have, including atrial fibrillation ablation, but as well as antiarrhythmics. And if we fail, and we don't do a fourth or sixth procedure on these patients, if we fail, I think also we have to think about an ablate and pace strategy, because that has also been shown to be beneficial. And now with new technologies in pacemakers like left bundle branch pacing, I think that will also be a very good therapy for these long-lasting persistent patients.
Well, exactly, I agree with you. Only, I think, shouldn't we predict these patients and not, as you say, as a recurrence and then eventually, but predict these patients and start very sooner, like the ECF-NET, it calls for early rhythm control.
Yep.
On the other hand, you've got early rate control as well. These patients, you may prevent a lot of healthcare costs and a lot of a better quality of life in these years, isn't it?
Yeah.
So we should be able to develop an algorithm.
Yep.
And
But you know, that's something you have to really create from the guidelines, because otherwise you can't tell a patient that's coming in for an ablation therapy, his cardiologist has referred him, and you say, you do have so many risk factors, we don't do it with you. But he's also feeling bad with the atrial fibrillation. So if we had such factors or such scores like the CHA2DS2-VASc, where we can say, yes, you have to be anticoagulated and you have not, and you have to be ablated, or you will better go with rate therapy or with antiarrhythmic therapy. If we would have that, I think it would help us. But we would have to use huge databases to know that.
Exactly, I agree, and we should change the infrastructure in Europe as well, I think. One last question, the chapter, or the Article 5 in Chapter 2.
Sorry, I have to...
Oh, okay, no problem.
in respect of your colleague, who has only
yes.
a few times. Thank you very much for...
Thank you.
The opposition will be continued by Dr. Verheulen. He's an associate professor in electrophysiology at the Department of Physiology at Maastricht University.
Yes, dear candidate, congratulations with this night work, and also your, of course, your supervisors here locally in Maastricht. I'm a biologist, so this is quite far from my area of expertise, but still I enjoyed it because I think the types of studies you did really provide a basis for rational healthcare decisions. Still, I have some questions, and I was surprised, first of all, on page 37, that healthcare costs, but also hospitalizations and sick days start to rise in already 2 quarters before a procedure. And you say that that's because that's when they're having their first AF episodes, right? It's not anxiety related to the procedure, it's really that they're then developing atrial fibrillation. So you're actually treating them already quite early, within 6 months of their first episode, right?
Yes, we try. But you know, this is hospitalizations. So it's maybe not the first happening of atrial fibrillation, but it's the first hospitalization for it. So this must be symptomatic patients at least. So this is not asymptomatic population, I guess, or mostly, because they come to the hospital with their first first diagnosis of atrial fibrillation. So they don't come for hypertension or for a heart attack or whatever. They come for atrial fibrillation because that is their first diagnosis, and that's how we pick them. So it's a symptomatic cohort.
And then they get their procedure, and in a way they're taken more seriously by the healthcare system. They have more better follow-up, better adherence to therapy. Could I simplify things enormously, and I think we'll disagree, but that we shouldn't try using antiarrhythmic drugs at all, that we should just, on the first presentation, first documented case of atrial fibrillation, we should do an ablation. And I would say an epicardial ablation. It's easier, more efficient. So where am I going wrong there?
No, you're not wrong. I think there are triggers for atrial fibrillation if it's in surgery, stress factors, infection, whatever, that may trigger your first episode of atrial fibrillation. And that's not the people that we will directly treat by pulmonary vein isolation. But it's already a risk marker for these patients. And maybe we see, okay, there's hypertension, which is untreated. We see their lipid status. We sometimes also look at their coronaries if they are in a 50 to 60 years age. So it's also probably a matter of other coronary or vascular disease. So I think that's what we are seeing in this cost incline in the months before. And then when we are struggling with the therapy because it's not working to only put them on a beta blocker, or it's not working after 1-2 cardioversions to put them on an antiarrhythmic drugs, they are still symptomatic with their episodes, then we are thinking about a pulmonary vein isolation. So that's also because that's also why we have this latency up to, I would say, 6 to 9 months until we really get an aggressive therapy on them.
Okay. And then I was, in one of your later chapters, interested in your ablation of low voltage areas.
Yes.
And I know that that's what many people do, but I still wonder about the rationale for that therapy. So low voltage area, as what some people call SCAR.
Mm-hmm.
What are you doing histologically when you ablate there? You're making a scar even scarier. Or
yes, that's
scarier.
right. Yeah, no, that's right. It's a kind of scar homogenization.
Mm-hmm.
So because scars, when they still have myocytes in there, they are prone to have re-entry circuits in there because you have slow conduction in there. So micro circuits, which might even also then promote or prolong atrial fibrillation episodes. And that's why we thought about taking out these diseased areas, fully take them out, so make a scaria, as you said, like we also did in the ventricle for long years with ventricular tachycardias. I think that's the same concept, to take out areas that have a very slow conduction, which could promote atrial fibrillation again.
Mm-hmm. And one of the ways to do that then is with that catheter you describe in one of the other chapters.
Yes.
Where the main advantage is the feedback, so that you can have shorter ablations at a higher power.
Yes.
And what's limiting output? What damage could you do in such
overheat,
an area?
yeah.
Mm-hmm.
What limits output is the overheating of the tissue. You have a surface, an endocardial surface overheating, which gives you a pop lesion, so a gas explosion, a small one, with the risk of tamponade and so on. So you can't go over the temperature limits. And here you have a direct temperature limit, temperature target, and that limits your watts. So that's why you can get much higher without overheating.
Mm-hmm. Okay.
Thank you. Martinek, the degree committee will withdraw in a minute, and the time allotted for defending your thesis has passed. The degree will now just will go to discuss your quality of your thesis and of your defense and of your presentation, and I request you and your Paranymphs company will await the results of our deliberations here in this room, and with this I temporarily adjourn this session. Thank you.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile or not. The line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile or not. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Hit the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. Better future that we go for. And Even though these nights seem long, I know that I am never on my own. Know you won the battle once you've grown. South side, 10 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and that. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and that. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Please be seated.
Martinek, the degree committee here present has assessed the quality of your thesis and your defense. Took some time, sorry for that. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor, and Professor Kreins is also authorized to confer upon you this academic distinction in accordance with Dutch university custom. But before he will do that, he will take off a declaration of integrity with you, and I invite your supervisor to now take the floor.
All right, please.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent and responsible?
Yes, I promise.
Okay. By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Martinek, the degree of doctor and grant you all rights attached by custom and law. And as evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and fixed with the official seal of the university.
Please be seated.
I'll give it to you.
Enjoying? Dear Dr. Martinek, Dr. Martinek, dear Martin, congratulations on your PhD, and also obviously congratulations to all your beloved. I must say it was a great pleasure to work with you on this thesis, to be your promoter together with Gerald. I'm not sure whether Professor Bruckner is now in the room.
The electricity broke down in his university,
so
because they digging a hole.
Digging a hole. Shouldn't do that while you're defending your thesis, come on. But together with him and Brigitte, Dr. Essers, I very much enjoyed working with you, because you are well learned, you always knew what to do. If there was a problem, you would solve it. And so without us promoting you a lot, you did this thesis quite efficient. An easy job for us. And I'm also very happy that Brigitte and Gerald, they tolerated me in the promotion team, because as a clinician I'm not very learned in health economy. You are, and you took up a very difficult topic there and brought it to a good end. We first met in 2019 during the first module of the International DASCAM course, then still with the late Professor Hein Wellens. You were selected for DASCAM from a large group of international applicants, and that was because you stood out for an excellent curriculum already then. And also an intriguing motivational letter. And in that letter you mentioned that you had a strong interest in taking the fastly growing Austrian EP to the next level. And I think in the meantime, well, that happened and is still happening. And you also wrote there, in this connection, it's important to not only expand collaboration between disciplines and hospitals, but also have physicians actually being involved in general healthcare management. And that's because their input in healthcare management is essential. After all, they are the specialists who really know what's important in clinical medicine and what should be done and what then eventually should be reimbursed. And your broad medical knowledge is reflected in your scientific work, which in turn feeds in this keen interest of yours in improving efficiency in healthcare. And that's where this thesis came from. The importance of this work is cannot be denied. It's among the first to show cost effectiveness of catheter ablation for atrial fibrillation, and as you explained, this is a very important remedy for patients' complaints, and doing ablations keeps patients out of hospital and reduces healthcare costs, and that's nowadays quite important. Today, during the defense, a lot of memories came up on the tracks and traces you left during the DOSCOM course. During DOSCOM, you displayed a sort of a natural leadership with your own flavor, in particular your rationality and your calmness, modesty, but sometimes when discussing you can be gently impatient, but you always remained fair and respectful to others, and so I would say you're undeniably charismatic. Most important, I consider you an intelligent person, someone who really knows how to make a choice wisely. And that's important. That's an important element for being a leader. Also connecting to your peers, that's something you can do very easy. And therefore you are also very successful in the national and also in international networks, including the DOSCOM network. And given all these qualities, I don't think it's a miracle that some time ago you were appointed head of department in the Ordensklinikum in Linz, in your country, in Austria. You are there a member in good standing of the Austrian Society of Cardiology, and your state of service also in the ESC and the ERA, they are excellent. In 2017, for instance, you served on the ERA Congress program committee. That's a demanding task, but also a very prestigious task, and you get to know a lot of people there, but they also expect a lot of from you, from all the members of the team. And the same year and beyond, you served on the ERA website and communication committee, and in 2020 you were an active member of this important European Examining Corps cardiology group. I always enjoy seeing you in action, whether as a researcher, but also as a highly renowned faculty member at international scientific meetings, like the one I was in Graz. In 2019, I visited this sister town in Austria, Graz, very beautiful town also. That was for the International Grazer Herzkreislauf-Tage. And you and your supporter of today, Christine Lemmesch, you invited me to the Aussteigerm festival in the city of Graz, and strolling the city, drinking some wine together, taking jolly selfies of the three of us. You once more demonstrated then your stoic character, because you were cheerful, yet calm, clearly enjoying, but also thinking of the days ahead, because you had to proctor at a large hospital, proctor a complex EP procedure, and well, that was all happening then. The selfies I keep for myself, but I leave you saying that you are a great example for many. And with that, I'd like to leave you and congratulate you again and all of the beloved ones of you, and wish you all the luck and pleasure in the world. Congratulations.
Thank you, Professor Kreins. Are we going to do more photographies in this building, or are we? Yes, we do. The full works. Okay. All right, then we'll look ahead for this. So the first thing we're going to do after I close this session is to make a photo with Dr. Way up on your on a very big screen. So it will take some challenges from the pedal, but she will manage. She's proficient in this task. Dear Dr. Martinek, also on behalf of the Maastricht University, I congratulate you with the degree you have acquired, and with these words I will close this session.
Promotor en de promotor links en rechts.